My guest today wears many hats in cardiovascular medicine: clinician, educator, and advocate. And he brings all of them to the topic of hypertension. Dr. Eugene Yang is a professor of cardiology at the University of Washington School of Medicine, where he serves as a medical director of University of Washington Medicine's Eastside Specialty Center and co-director of the University of Washington Medicine Cardiovascular Wellness and Prevention Program. He holds the Carl and Renee Benke Endowed Chair for Asian Health, a reflection of his long-standing commitment to cardiovascular equity and risk reduction across diverse populations. Trained at Stanford and Penn, Dr. Yang has built his career around one central idea: that the best cardiology is preventive cardiology. He has served as chair of the ACC Prevention Cardiovascular Disease section and is currently course chair of today's topic at ACC 26, the Renal Denervation Workshop. And that's what brings us here, because renal denervation sits at the intersection of everything Dr. Yang cares about: blood pressure, lifestyle, medications, and what happens when all of this is still not enough. Dr. Yang, thank you for joining us today.
Thank you for
So,
having me.
of course. So hypertension remains one of the most prevalent and undertreated conditions in cardiovascular medicine. And for patients whose blood pressure stays uncontrolled despite lifestyle changes and multiple medications, the options have historically been limited. Renal denervation is a catheter-based procedure that targets the sympathetic nervous system. And after a rocky road through early trials, it's now FDA approved and finding its place in guidelines. But how does it actually fit into a real clinical workflow, and who is that right patient? Dr. Yang, my first question for you, to setting up the stage into renal denervation. So renal denervation has had quite a journey. Early hype, a major setback with Simplicity Hypertension 3, and now what feels like a real comeback. So for clinicians who tuned out after that disappointment, what should they tune back in?
Yes, thank you very much, Dr. Diab, for inviting me. I think the early trials, I think, unfortunately, uh, used early technologies. And so I think what's great about our cardiology profession is that people are very innovative, are willing to try new strategies. And so while the initial trials, with Simplicity Hypertension 3, were really unfortunate from the standpoint of not demonstrating clear benefit, people went back to the drawing board and said, maybe we redesign the catheters, we look at new technologies. The original catheter, was a single electrode. The new technologies using radiofrequency, have like a spiral multi-electrode catheter, which is different. Additionally, another company, developed ultrasound-based technologies to perform renal denervation. And so those new technologies really advanced the field to show more sustained reductions in blood pressure that were not observed in the original clinical trials.
Okay, yeah. So before we dive in, when we say on a background of lifestyle and medical management, how optimized does that background need to be before RDN even enters the conversation?
Yeah, that's a great question. I think that, as a hypertension specialist, I think I try very hard to make sure that I've done everything to rule out things that may be causing elevations in blood pressure. So we need to make sure that patients are measuring it correctly by using a validated blood pressure device. We also need to show them exactly how to measure blood pressure correctly, which is something that many clinicians don't have time to do. So I spend the time to show them how to measure it correctly in the office using a validated device that you can get on validatebp.org, which lists devices that have gone through the appropriate validation protocols. And then look at other key factors: medication adherence, right? So we need to make sure that patients are actually taking their medications. Within our electronic health record, we are able to at least get a sense of whether they're filling their prescriptions or not. So I can see that. When you look at what we call pseudoresistance, the primary driver of pseudoresistance is actually medication non-adherence. So that's actually the number one cause. And then some of the other factors that are also common are related to measurement and using appropriately validated measurement devices. But that's very important. Other things that we also do specifically in my practice is to look at secondary causes, right? So obstructive sleep apnea is very common. In the 19 years I've been practicing at University of Washington, I think I've only had 2 or 3 patients who I've referred for sleep studies who've had a normal test. So that means that almost everybody has some degree of sleep disordered breathing, and treatment with positive airway pressure significantly improves, well, at least modestly improves their blood pressure if they use the machine appropriately. So making sure pseudoresistance has been ruled out, making sure they're taking their medications and learn how to measure it correctly, very important. And then finally, ruling out secondary causes.